I think PARP inhibitors are here to stay now in metastatic breast cancer and maybe eventually also in early breast cancer, depending on the Olympia study, which hasn't read out yet. But in metastatic, we now have approval in Europe for olarparib and in the US for olarparib and talazoparib. So I think now it's time that we change the way we practice and incorporate them. And that's not very easy because it's only probably about 5% of the unselected population in luminal as well as triple negative breast cancer that do have a mutation. And we have to basically screen everybody now for germline BRCA mutation in the metastatic setting, and ideally before we start any therapy in the metastatic setting, and then to incorporate PARP inhibitors in those patients that do carry a germline BRCA mutation.
And is there anything being done to overcome the issue of PARP inhibitor resistance?
I don't think we're there yet. I think the major clinical objective is now, since we only have had approval in Europe for 2 months basically, is to change the way we practice, assess germline BRCA status, and then treat those patients. And it's going to be very difficult to sequence because in luminal breast cancer, obviously, we have CDK4/6 inhibitors, so probably PARP is going to be after CDK4/6. In triple negative, we also have with the atezolizumab data now good options for patients with PD-L1 immune cell positivity. So sequencing is important, and then we can sort of see what we do afterwards. And I think research will be going on there in order to see how we can optimally use the PARP inhibitors. There are some very interesting early data on combining immune therapy with PARP inhibitors, but we also know that either substance, be it the PD-1, PD-L1 targeted agent or the PARP inhibitor given first, will sensitize the tumors for the other. So there's a lot of exciting data out there.